So hey everyone, today's topic is infective endocarditis. So what is infective endocarditis? It's basically an infection of lining of the heart chamber and heart valves that is caused by bacteria, virus and fungi. Okay. What is infective endocarditis? When the lining of the heart chamber and the heart valves there is infection that is basically produced by bacteria, virus and fungi, it is known as infective endocarditis. Okay. So infection may be bacteremic. Bacteremic means when the bacteria enters your blood, that is known as bacteremia. So infection may be bacteremic. Okay. That is common during dental and surgical procedures where you have there is direct connection of blood with the environment, with the oral environment. Okay. So etiology. So the main organism is Streptococcus viridans. It's asked very commonly in MCQs, in NEET. Okay, what is the main organism, and also in vivas. So main organism is Streptococcus viridans, that is responsible for almost half of the bacterial endocarditis. Okay. Others are Staphylococcus and Enterococcus. Now, what are the aggravating factors that aid in formation of infective endocarditis? So, if there is any pre-existing congenital heart disease like patent ductus arteriosus, arterial septal defect, or there is rheumatic heart disease, cardiac valve anomalies like mitral insufficiency, then prosthetic heart valve, scar tissue or prosthetic coverings in CVS. So these factors they add on to the formation of infective endocarditis. So we generally see that our seniors tell that always give antibiotic prophylaxis to IE patients before starting any procedure. So why is it so? Why you have to administer antibiotics in cases of IE patients? Because it only prevents the colonization of bacteria in the areas of susceptibility. If they have these aggravating factors, so these are the susceptible areas: rheumatic heart disease, PDA, ASD, these are the susceptible areas. So that the bacteria does not colonize here, we give antibiotic prophylaxis, okay, to prevent colonization of bacteria in the areas of susceptibility. And the most common bacteria that is responsible for IE is gram-positive cocci, that is predominant in the oral aerobic microflora. This is most commonly responsible for IE. Okay, this is also an important point for NEET and Viva. Okay, now management. So for management, first is prophylactic antibiotics, everyone knows. Then what are the various bacteremic dental procedures? What do you mean by bacteremic dental procedures? Those dental procedures via which the bacteria enters the where? Enters the bloodstream. Those procedures via which the bacteria enters the bloodstreams, these are known as bacteremic dental procedures. Bacteria enters bloodstream, so it will cause bacteremia. So these are the bacteremic dental procedures. Now in bacteremic dental procedures, there are two things. One is higher incidence of IE, or higher chance of getting or having IE, that is higher incidence, and there is lower incidence procedures. Okay. In higher incidence comes extraction and various periodontal procedures like scaling, root planing, very common because there is bleeding. In SRP there is huge bleeding, so highest chance. Okay. Then probing. In probing also, if there is bleeding, there are chances. Subgingival antibiotic fiber or strip placement, dental implant placement is very high chance. And in RCT, not the intracanal preparation. In RCT, only beyond the apex, those surgeries, periapical surgeries. In RCTs, periapical surgeries, okay, they have the higher chances of getting IE. Then prophylaxis, where bleeding is suspected, we are giving prophylaxis, then there is higher chance. And in LA procedures, the intraligamentary procedures and the intraosseous procedures, these two LA techniques, they have higher chances of getting IE. Okay, for short form I am using infective endocarditis as IE. Now in lower incidence comes all the restorative procedures, other LA techniques other than the intraligamentary and the intraosseous. All the other LA techniques are safe. They have lower incidence of IE. Then intracanal instrumentation, that is the basic RCT procedure, it has lower incidence. Radiographic techniques. Radiographic techniques, there is no chances of bleeding. So obviously rubber dam placement is also. Post-op suture removal, fluoride treatments, RPD appliance placement, and also plus one is ortho appliance placement. Okay, ortho appliance placement, it also has low incidence of IE. Now comes the most common part of IE that is asked in your exams, that is the major and minor criteria of infective endocarditis. So in major criteria comes, first is the positive blood culture for infective endocarditis, then evidence of endocardial involvement, then third is clinical evidence of new valvular regurgitation, fourth is positive serology, fifth is positive identification of a microorganism from blood culture or excised tissue using molecular biology methods. These are the 5 major criteria. Okay, we will discuss in detail later. Then comes the minor criteria. Minor criteria, first is predisposition. So if there is fever more than 38 degrees centigrade, 37 point something is the normal body temperature. Okay, so if there is fever, then vascular phenomena, immunological phenomena, and microbial evidence. Now we will discuss in detail all these. Okay, so what are the major criteria? Positive blood culture for IE. So we have to do 2 separate blood cultures, and they should have a 12 hour apart, or all of 3 or a majority of 4 or more separate blood cultures with first and last drawn at least 1 hour apart. Okay, then second is evidence of endocardial involvement. So we will see a positive echocardiogram for IE if mobile intracardiac mass on valve or supporting structures, or in path of the regurgitant jet, or on implanted material, without any an alternative anatomical explanation. Okay, if there we see in the echocardiogram, we see there is a mobile intracardiac mass on valve or the supporting structures, or in the path of the regurgitant jet, or implanted material, there is an intracardiac mass without any alternative anatomical explanation. Then presence of abscess, presence of intracardiac mass, and new partial dehiscence of prosthetic valve or new valve regurgitation. If these 3 things are present in the echocardiogram, then it is positive. Third is clinical evidence of new valvular regurgitation. Fourth is positive serology for Q fever or other causes of culture negative endocarditis such as Bartonella species and Chlamydia psittaci. Okay, positive serology for Q fever, this is very important. Which fever? Q fever. Okay, then positive identification of a microorganism from blood culture or excised tissue using microbiology methods. So these are the 5 major criteria. Okay, then comes the minor criteria. Minor criteria, there is fever, predisposing heart condition or IV drug abuse. Okay, if there is any heart condition that is predisposing or there is intravenous drug abuse, first is predisposition, second is fever more than 38 degrees centigrade, third is vascular phenomena, if there is any major arterial emboli, septic pulmonary infarcts, any hemorrhage, okay, that is vascular phenomena. Then immunological phenomena, if there is presence of glomerulonephritis, Osler's nose, Roth spot, ESR, this is very important. High ESR more than 1.5 times the upper limit of normal. So always remember the normal ESR. Okay. More than 1.5 times the upper limit of normal, or high C-reactive protein CRP. High CRP more than 100 mg per liter. If these things are present, then there is major chances of IE. But these are the minor criteria. And the fifth is microbiological evidence, positive blood culture but not meeting major criteria as defined above. Okay, additional modifications to the Duke criteria appear to improve diagnostic sensitivity while retaining specificity. Now we come to the dental management. Okay, so in dental perspective, what we have to do? So from purely dental standpoint, it is obligatory to prevent the onset of infective endocarditis in view of the high morbidity and mortality. Depends on what? Identification of patients at risk, planned preventive dental care, deciding which treatments require antimicrobial cover, giving appropriate antibiotics at the appropriate time. This is very important. Appropriate antibiotics at appropriate time, and identification of patients at high risk for IE. We have to first able to identify patients with high risk of IE. These include mainly those which have previous cases of endocarditis and prosthetic cardiac valves. Okay. And the last thing is, this is the antibiotic prophylaxis regimen that is asked everywhere. So, ALA, amoxicillin to local anesthesia. Under local anesthesia, if you are doing something, we have to give amoxicillin 2 gram orally 1 hour prior to dental procedure. And if allergic to amoxicillin or allergic to any of the penicillin in the last month, clindamycin orally 600 mg 1 hour prior to the dental officer or procedure. And if general anesthesia, then amoxicillin IV plus orally 1 gram at induction and 0.5 gram 6 hours later. Allergic to penicillin, then vancomycin IV 1 gram over 1 hour before the procedure plus gentamicin IV 120 mg over 1 hour. Okay, that's all for infective endocarditis.